Okay, we're going to talk about the use of ultrasound in pediatric patients, both in terms of cardiac ultrasound and also some useful applications in the abdomen. When we look at the heart, we want to use the P21 or the phased array transducer. It's got a small footprint, and so it's really good for getting in between the ribs and seeing the heart, which has to be sometimes a deeper structure in the body. So we have to get the sound to sort of penetrate deeper into the body, which is why we like to use this lower frequency, small footprint phased array transducer. Whenever you look at the heart, I think it's helpful to look at it in multiple windows. The first window we think about is a subxiphoid view, and what you're going to do is you're going to sort of follow the liver edge along the subcostal margin until you can see the heart. And once you get around to the subxiphoid area, you're going to actually aim the beam towards the chin of the patient. Now, you always think about the heart sort of being on the left side of the screen, but actually what we're really trying to do is aim the beam towards the patient's chin, and in doing so, we still use that liver as our margin. You see, the subxiphoid view, it's necessary to use the liver as the window to see the heart. If we were to inadvertently aim the beam towards the patient's left, then we wouldn't have the liver anymore and we wouldn't be able to see the heart at all. We'd be shining the sound right up into the chest. So in patients who have really small livers for whatever reason, this subxiphoid view is not a very good window. The larger the liver, the better this window is. In order to get the liver to really come out from under the rib cage towards the probe, what you can do is have the patient take a deep breath. And what we see in the subxiphoid view is the following. Here's the liver, and then we can see the right ventricle and then the left ventricle. Here's the right atrium, and here's the left atrium. So the right side of the heart is closer to the liver, whereas the left side of the heart is further down into the body. And we can see over here, once we have a pericardial effusion, it's seen as a separation between that sort of anterior pericardium and the myocardium. In fact, this pericardial effusion wraps itself all the way around, including around the posterior region of the heart as well. Now, about 15% of the time, because some patients have small livers or other issues, it's really difficult to obtain a subxiphoid view. So it's good to know some other tricks up your sleeve, such as the parasternal long axis. And as its name suggests, it's para next to sternum in the long axis of the heart. And we use the cardiology orientation, which is where we take the indicator and we aim it this way so that the apex is towards the indicator on the screen. So again, this parasternal view, here's our sternum right here. We're almost actually on top of the sternum. We're just to the side of it, and that's my indicator right there. We can see it's that little nipple with this little groove next to it, and we're going to aim that indicator towards the patient's left. Therefore, the apex of the heart will be on the side of the screen where the indicator is, and we can see the indicator is over here, which is why the sort of the apex of the heart is seen over here. We can see it also here as well, apex of the heart towards the indicator, because that's which way we aim the indicator. Now, this is a three-chambered view of the heart. We can see the right ventricle, and we can see the left ventricle, and here's the left atrium. And basically the blood is going from the left atrium through the mitral valve into the left ventricle, and then it gets pumped out the aortic outflow tract.
Screening athletes for heart problems. Dr. Barry Ramo reveals how certain tests can save lives.
It seems like every week we hear about competitive athletes dying suddenly on the playing field. The question is, should competitive athletes be periodically screened for heart problems before they compete? A recent study published in the British Medical Journal found if athletes were screened before an event, the risk of sudden cardiac arrest could be detected and lives could be saved. In Italy, where all athletes are screened, scientists looked at more than 30,000 athletes who underwent an electrocardiogram and found almost 5% of them had some heart abnormality that could lead to sudden death. According to researchers, a young athlete dies every 3 days from an undiagnosed heart problem in the U.S. That's because in most cases the problem goes undetected until they compete. The major cause of sudden cardiac death in athletes is a disease called hypertrophic cardiomyopathy. Often patients with this problem will have a family history of the disease, there'll be a family history of sudden cardiac death, or they'll have some physical findings on examination. But the best test is an echocardiogram, which is an ultrasound of the heart. So far, we're not doing routine screening of athletes, whether they're professional athletes or whether they're just regular high school athletes. But that might be something in the future to weed out those kids who are at high risk for sudden cardiac death. For HealthBeat, I'm Dr. Barry Ramo, KOAT Action 7 News, live this morning.
So with hypertrophic cardiomyopathy, what happens is the septum of the heart gets very thickened, and once it gets thickened, it gets harder for the blood to get pumped out the aorta. And you can see, in fact, this blood here doesn't even get out the aorta. Once the patient's exercised and this gets even a little bit enlarged, the blood can't get back out that aortic valve. And so what you can do is, once you make the diagnosis, you can come in and inject alcohol in here, and that shrinks down that interventricular septum, thereby making it easier for the blood to get out the aortic valve. And the whole trick is picking up the diagnosis. It's very difficult to do on physical exam, if not impossible. You can see some of the symptoms listed there, but essentially what happens is the physical exam can only pick up about 3% of the patients before they experience sudden cardiac death. One study found that the incidence of sudden cardiovascular death in young competitive athletes declined in the Veneto region in Italy by 89% once they introduced routine hypertrophic cardiomyopathy screening of athletes. And a bedside echocardiogram can detect hypertrophic cardiomyopathy with 80% accuracy. What you're going to do is you're going to look at that septum. And we can see this is the septum and that peristernal long axis. That's why I'm always talking about the peristernal long axis, because you can see that septum so well. And so at the end of systole, where it's the thickest, you would drop some calipers along this area right here. And if the calipers are less than 15 millimeters, then, well, actually a normal septum is anywhere from 0.8 to 1.2 millimeters. Now, in somebody who undergoes a lot of exercise, sometimes hypertrophic cardiomyopathy can be mistaken for something known as athlete's heart. Now, both involve a growth of the myocardium. However, athlete's heart is generally not correlated with the incidence of sudden cardiac death. While hypertrophic cardiomyopathy can be linked to family history, athlete's heart arises purely as a function of intense exercise, usually at least an hour a day, every day. Since the body is operating at high training levels, the heart adapts and grows in order to pump the blood more efficiently. Stoppage of exercise for 3 months generally leads to a decrease in the wall and the septum thickness in those with athlete's hearts, whereas those with hypertrophic cardiomyopathy exhibit no decline. So people with athlete's heart do not exhibit an abnormally enlarged septum, and the growth of the heart muscle at the septum and the free ventricular wall is actually symmetrical. Whereas with hypertrophic cardiomyopathy, we see asymmetrical growth and a less dilated left ventricle. This in turn leads to a smaller volume of blood that can leave the heart with each beat. Now, you can see that with athlete's heart, it's usually less than 15 millimeters at the septum, whereas in hypertrophic cardiomyopathy, it's greater than 15 millimeters, and it's not symmetric, and we want to definitely get a good family history from these patients. And if you're worried about it, you can check them again in 3 months if they stop exercising, and athlete's heart should return to normal, whereas it stays the same with hypertrophic cardiomyopathy. Another thing that happens is you can get a systolic anterior motion of the anterior leaflet, which further obstructs the outflow tract. So here is a cardiac ultrasound showing a systolic anterior motion of the anterior leaflet of the mitral valve during systole. So as the heart's squeezing during systole, look what happens. You can see that anterior leaflet flip up anteriorly and block that outflow tract. I'll get my arrow out of the way so you can see it, and see if I can pause it right when it happens, right there. So we can see here at end systole, this leaflet flips up and actually occludes the flow of blood trying to get out of the aorta. That's another finding with hypertrophic cardiomyopathy, and you can see how thick this septum is here. Now, Switching gears a little bit now, talking about pericardial fluid. That's another thing you want to look for in kids. And what you look for is an anechoic or jet black fluid in the pericardial space. We see this with pericarditis. We see this with trauma. It can be from uremic causes, malignant causes, and sometimes we don't know what causes it. We see both acute and chronic pericardial effusions, knowing full well that in the acute patient, actually anywhere from 80 to 200 cc's, depending on the age of the patient, is enough to cause the fluid in the pericardial space to be greater than the ability of the ventricle to fill. In other words, that's called pericardial tamponade, that the heart can no longer expand in the sac of fluid and the patient can die. Now, chronically, you can see huge pericardial effusions. In fact, this picture here is one in which we did an ultrasound-guided pericardiocentesis, and you can see this. That's about a liter of fluid that I drained off of a patient because she had uremic pericarditis from renal failure, and basically we were able to take a liter off her heart because it took so long to accumulate that the pericardium was able to stretch over a long period of time. But when you get stabbed, the pericardium can only accumulate up to 200 cc's at the most before you get to pericardial tamponade. Now, sometimes the material can look echogenic with various shades of sort of swirling echoes in there. You can see different types of effusions like pus, if it's an infection, blood with fibrant or malignant effusions. And the other thing is, after somebody has a recent upper respiratory infection, we do see a lot of sort of physiologic, asymptomatic, trivial pericardial effusions. It's not uncommon to see that at all. I see this on models quite a bit, actually. So it's just something to think about. And then the next question somebody always asks me is, how can I measure the amount of fluid around the heart? And the answer is you cannot using ultrasound. The only way to measure it really is to extract it. And so unfortunately we can't really measure it. It's just, you just sort of get an eyeball appearance of it. Basically, if there's more than a centimeter stripe of distance between the pericardium and the myocardium, that's when I start to get a little concerned about it. Less than a centimeter fluid stripe doesn't bother me too much. And you can see that these are 1 centimeter hash marks over here on the scale, and this is somebody who's got quite a large pericardial effusion. In fact, that was from the patient you just saw in that last image here. We drew 1,000 cc's of fluid off this particular heart, and I mean, there's portions where there's like 5 centimeters of fluid basically between the pericardium and the myocardium. So this is a very large pericardial effusion. Here's a smaller one here, and actually people are always asking me about this one. I'll just point out the reason I get questioned about it, because people see this right here. They see these little material in the pericardial space, and they say, what is that stuff in there? And I say, I don't know. I don't really care. I know that there is a pretty good sized stripe here, more than a centimeter, and in fact it stretches to go around posteriorly as well around this patient's heart. So that's a little bit concerning. So yeah, so what's in there, I'm not sure. Could be some loculation, some fibrous material, could be some fat, but my eye is really trained to look for the pericardial effusion in that subxiphoid view. Here's another subxiphoid view showing another pericardial effusion, a couple centimeters there of a fluid stripe seen anteriorly. We can also see that fluid marching around posteriorly as well. Now in the peristernal long axis, this is what a pericardial effusion looks like here, and we can see the heart swinging back and forth a bit. We see that when we see larger pericardial effusions, and so during systole, at the end of systole, we can see the heart, the pericardium up here pull away, the myocardium pulls away from its pericardium. We also see it posteriorly as well. But if you look very closely, I want you to pay close attention to something here. This is the descending aorta. This circle right here is the descending aorta that we see on the peristernal long axis. And here is this pericardial effusion that tracked itself anterior to the descending aorta. In other words, it's between the left atrium and the descending aorta. We can see this wedge of fluid tracking up here. And that's what defines this as a pericardial effusion. If this fluid was to track posteriorly behind the descending aorta, then we'd be more worried about a pleural effusion or fluid in the chest. Now this next scan is somebody who came in with abdominal pain, right upper quadrant abdominal pain, a 4th-year medical student. last summer did this study, went to the bedside, looked at the gallbladder, scanning through the gallbladder, but in the corner of his eye saw this down here on his scan and thought, that's strange, what is that? And focused in on it more, and look at this. This patient has quite a large pericardial effusion there, and this patient actually ended up needing to go to the cath lab to get a pericardiocentesis. We can see there's 2 to 3 centimeters here of fluid between the anterior pericardium and the myocardium, and this was a big-time incidentaloma, incidental finding where we were looking for gallstones. The patient had abdominal pain. Yeah, there's some language barrier there. They came for the abdominal pain. They stayed for the pericardiocentesis. So what really is pericardial tamponade? Then you're probably wondering. Well, pericardial tamponade is when you have diastolic collapse of the right heart, and that's the main thing. So during diastole, you would expect the heart to fill, but if it paradoxically collapses during diastole, that's when there's so much fluid around the heart in the pericardium that it's causing the heart to collapse when it should be expanding. And that's the sonographic definition. The clinical definition is large pericardial effusion plus hypotension or plus severe shortness of breath. Sometimes we see stuff around the heart. It could be epicardial fat, so you want to be a little careful there. What do you think is going on in this view here? A couple things I can see. Number one, it's a subxiphoid view. This is the liver here. We can see the pericardium tracing out here. This is the myocardium, and it's a little subtle, but do you see this area right here that's adjacent to the myocardium? That's epicardial fat. Now, this image is overgained. Yes, like you, I feel like I need to wear sunglasses when I look at it, but just keep in mind that this is a fat pad here. However, this out here is something different. What do you think this is? So far, the pericardial effusions that you've seen have all been anechoic, but this one's got basically some echoes to it here, and this is what a clot looks like. This is basically a patient who's got tamponade with a blood clot in the pericardium. How do I know this is tamponade? Well, look at during diastole, we see the trampoline effect. It looks like there's a little tiny person jumping up and down on this patient's right ventricle, and it actually, the right ventricle decreases during diastole, and that's the sonographic definition of tamponade right there. Also, this patient was very symptomatic, very short of breath. Now, the other thing that we can see is cardiac standstill. This is actually a video of a heart that's no longer moving. It looks like a still image, but it's not. It's actually a video. And these are the chambers here. Sometimes the heart is hard to pick out when it's not moving. You're used to seeing the heart move. But when the patient expires and the heart stops moving, we can see it here. And there's been several studies to show that once the patient has cardiac standstill, they have a near universal 0% survival rate. And so this may be one particular endpoint that you may be looking for in some of your codes. Now, here's a patient who was in a car accident. It was a blunt traumatic full arrest. And when we have a patient with blunt traumatic full arrest, what we usually think there's really not much we can do for them. With penetrating trauma to the chest with pericardial effusion, we immediately do a thoracotomy, but with blunt trauma, it's less clear. Well, in this particular patient here, they didn't actually have a pulse at all. We felt no carotid pulse, yet we saw this heart beating around quite a bit, swinging around in its sac of fluid there. Clearly, this is pericardial tamponade. In the setting of blunt trauma, it was a little bit confusing. When you look at the mechanism a little bit closer, patient wasn't wearing a seatbelt, hit the sternum, and probably a rib fractured and poked the pericardium, causing this pericardial tamponade. And so what's the next step in the trauma bay when we have somebody who's got blunt traumatic full arrest with pericardial tamponade? Well, the next step in the trauma bay is not to do a pericardiocentesis, but rather do this, which is a thoracotomy. And so we did. We used the ribs. We cut the patient open, and then we used the rib spreaders to spread apart the ribs, and we get all these clots out of the chest and out of the pericardium as well. And when you continue the thoracotomy all the way to the other side, that's called a clamshell. But it's something we always look for now in our blunt trauma patients and who are in cardiac arrest to try to rescue them from that. And the person that you see right here, it did come back to life and actually was discharged from the hospital, even though they got an emergency department thoracotomy. So we've had several patients now over the years survive an emergency department thoracotomy who had blunt traumatic full arrest. Now, switching gears now, I'm going to talk about CT scans in kids. And I know this is an ultrasound talk, but I want to just bring your attention to something that many of you may not be aware of, and that's that we've had an unbelievable increase in the amount of CAT scanning going on throughout our emergency departments. And this was a study published 3 years ago showing just that, that over the prior 6 years, from 2000 to 2006, we saw just gigantic increases in the amount of CT scans for the various modalities. And this is not in adults, this is all in kids. And so it's something to be concerned about, because kids respond to radiation a little bit differently. And as this chart shows here, kids, they basically have more radiosensitive tissue, and they live a longer life, and so cancer can develop. It can take in certain cancers that take a longer time to develop, they will develop in younger people because they have longer time to live to get those cancers. And so this is what happens when you get this increase in CT scans. You can see here, this is the estimated radiation-induced cancer risk in kids compared to adults. And as friendly as we try to make our CT scanners for kids, it's really not a friendly thing to do to a kid to CT them. Let me show you this here. This is an excess cancer mortality rate by age at exposure. And so here is the number of, this is basically 100 millisieverts of radiation, and the number of cancer deaths per 100,000 patients who were exposed to 100 millisieverts of radiation. So that's a couple of CT scans, 2 or 3 CT scans right there. And so you can see if at an early age, basically this is the fulcrum right here. Once you're below the age of 35 and you're exposed to, 3 CT scans or so, you have significantly higher rates of cancer than when you get it when you're over the age of 35. So it's just something to think about. I try to really curtail my use of CT scans in younger patients whenever I can. One particular strategy was suggested by Lamaris in 2009, who said, well, what if we used ultrasound first and then CT scans? This was 1,021 patients for the diagnosis of urgent conditions. And while CT was significantly more sensitive than ultrasound, it is a better test in terms of its accuracy. The overall highest sensitivity actually used a combined approach using initial ultrasound, then CT, and this actually was able to reduce radiation by 50%. So that's something to think about. If we got better with ultrasound or really thought about it a lot more, especially in kids, we could avoid the need for CT scans. So in about half the time. So I'm going to go through how we can use it in the pediatric abdomen now in terms of 3 potential diagnoses: pyloric stenosis, intussusception, and appendicitis. So it turns out that ultrasound in kids are good matches for one another. Kids are very what I call sonogenic, and it's because they don't have a lot of fat, basically, and they're small, so we can use higher frequency transducers, and they have a lot of cartilage compared to the amount of ossified bone, and so ultrasound goes right through cartilage very easily. It does once the bones get ossified and they get very dense, the sound gets reflected. So kids have lots of cartilage, which is nice for ultrasound. And as opposed to putting a child who's squirming around in a CT scanner where they have to sit still, you can actually plop the child right down in mom's lap and scan the child right there without any sedation at all. So you don't need to sedate them, which has mixed. Whenever you sedate a kid, you have to sort of control their airway, and it puts them at risk for a complication there. So we do it when we need to, but if we can avoid that, it's a good thing. And this is an example here of a patient who's got appendicitis, and this is what it looks like. This is the skin line up here. This is some muscle, and this is the appendix swollen right here, and it's greater than 6 millimeters. Actually, wall-to-wall measures 1.03 centimeters. And that's what acute appendicitis looks like. Which probe do you think we're going to use? Well, normally when we look in the abdomen on adults, we have to use this probe here, but on kids, we actually get to use this probe here, my favorite probe, because it's got such high frequency and makes such pretty images. Now, one of the techniques that you want to use whenever you work with kids, of course, you want to use the high frequency linear probe with the patient in the parent's lap. Lie the patient supine as best you can. It actually helps to bend their knees a little bit too. But it's this part right here, warm gel. It's amazing how the cold gel in the kid can, it's like you're bringing a little squirrel over to eat a nut out of your hand, and all of a sudden you freak them out with the cold gel. So put some warm gel on there. We have a gel warmer that we keep a bottle set aside for kids with. It's actually in our heater for our warm blankets as well. So that's the way to go. Now let's first talk about pyloric stenosis. So pyloric stenosis is where you get thickening of the hypertrophy of the pyloric muscle here, and it occurs in about 1 to 250 kids at a male to female ratio of 4 to 1, very, very early in life. That neonate that comes in with non-bilious projectile vomiting, every single one of these kids is consideration for pyloric stenosis. Now, on physical exam, it's historically shown that you want to palpate the olive, and basically you push around on the abdomen trying to feel this thing right here, which is this stenotic hypertrophied pyloric valve. And actually, palpating the olive was only shown to be present in about 23% of patients, whereas ultrasound has very good test characteristics to pick up pyloric stenosis. Now, the ultrasound images of the gastric pylorus, when it's greater than 1.6 centimeters in length or 4 millimeters in thickness, and so right here, this is the length right here. If that distance from here to here is greater than 1.6, or if the thickness is greater than 4 millimeters, then we think about pyloric stenosis. And you do this in real time, and you'll see peristaltic waves from the proximal stomach, which do not transmit the fluid down through the fundus. So this is the proximal stomach here, and it'll be peristalsing. The stomach will be squeezing, but it can't get the fluid through this stenotic pylorus. Some of the limitations here is if the patient's crying, you have to kind of do this between the cries. So as the patient goes, wah, you can't really do it then, but when they, between the cries, and they go to take a breath, everything relaxes, and that's when you can get in and get a good view. So sometimes you only get the view while they're crying between the cries. And if there's a lot of bowel gas, if the patient has a bowel obstruction, there's a lot of bowel gas everywhere, this can be a somewhat difficult study to do. And if they've been crying a lot, sometimes they swallow out of air, and we know air is the enemy of ultrasound. So instead of being nice fluid in here, or formula, whatever this is, there's air in there, and that can get in your way. So that has a couple of limitations. But a lot of times when the child vomits, a lot of gas comes out of the stomach, and we actually get rid of that air. So vomiting can be a helpful thing when doing ultrasound. So the technique is basically you want to give the patient some clear fluid to drink, some Pedialyte, and let them suck that down if they can, and that will really make this job way easier. And aim the indicator to the patient's right, and then you start in that kind of right upper quadrant area down towards, or so to say, over towards the epigastric area. And in the transverse section, it looks like a donut, and you just saw what it looked like in the longitudinal section. These are the two views here. We can see the pyloric canal length if it's greater than 14 millimeters, if the thickness is greater than 3 millimeters, and if the diameter, the diameter here is more than 11 millimeters. That's suggestive of pyloric stenosis. We can see it over here to the diameter, whereas the muscle thickness is going to be from here to here. This is the muscle thickness here, and if that's greater than 3 millimeters, we worry about pyloric stenosis. So those are the three things: the canal length, the diameter, and then the muscle thickness here. Again, this is how it looks when it's positive. And we're going to change gears now and talk about intussusception. Now, intussusception is where you have telescoping of the bowel segments. So you get the, and I had to kind of relearn this anatomy here, the intussusceptum is what telescopes into the intussuscipiens. Intussuscipiens. I can't pronounce it, obviously. But that's the idea. You get this is called intussusception. And this is what it looks like when you're in the operating room and you're demonstrating it real time. And it causes full-blown intestinal obstruction, so patients come in with, not surprisingly, the triad of colicky, abdominal pain, vomiting, and bloody stools. Unfortunately, that classic triad, like all classics in medicine, is only present about 20% of the time. The typical age range is 3 months up to 2 years. Now, there is something called the current jelly stools. It's where you have blood plus poop. It comes out looking like this, current jelly. And luckily, ultrasound, very, very good with intussusception. It's got about 100% sensitivity to pick it up. And the way you do this is you can, and this is an example here of placing the patient in a warm water bath here and holding the legs together as we're doing the ultrasound. And by holding the legs together, specifically by sort of squeezing the buttocks together, that can help actually reduce some of this and fix the problem. But to diagnose it, though, we're here with the ultrasound probe, and we're looking at the ascending and then across to the transverse colon, any areas that's non-peristaltic, because these intussusceptions, they don't peristalse. Normally, peristalsis occurs about every 8 to 10 seconds, but you can stare at this bowel, it's not going to peristalse, and you'll see a mass or a target sign. Now, this is what normal intestine looks like. It's got sort of a layered appearance, it's easily compressible, and it's got intermittent peristalsis. This is, we can see here in the long axis of this bowel, kind of cruising along, there's air in it, and so the air makes it so we can't see the rest of the bowel, which is normal. And in a short axis, between peristalsis, this is normal bowel here, seen in a short axis here, when it's in the middle of peristalsis, all the air gets kind of pushed aside, and we see the actual rugae here of the bowel. And that's what normal bowel looks like in a normal patient. These are blood vessels down here, and this is, again, what normal intestine looks like up here. Now, with intussusception, on the other hand, here's the problem. In the short axis, it really does look like a donut. It's got this target configuration. In a long axis, we call this the, sometimes it's called the hay fork sign or the pseudo-kidney sign. And but this is what that target shape looks like. You can see why ultrasound has such good test characteristics here to pick up this, because it's got that target formation. Here's another example here of the target sign of intussusception. We can see layers of bowel seen with that hypercoic segment around that inner layer there. This is basically like a little target symbol there. It's all that bowel invaginating in with the mesentery in it, and that's what causes these layers. And here's another example here of intussusception, and we wrote on here no peristalsis seen. Again, it's that targeted layered appearance. Another example here of a pretty straightforward case. We see layers of bowel along with the hypercoic segment around the inner layer due to the invagination of the mesentery that came through here. This is the actual video of this patient. We're right around the epigastric area, under the liver. We moved it over to the right upper quadrant, and it's where the ascending, the transverse colon came together. We can see the intussusception starting to appear right there. And that's it right there. There's actually kind of a long axis of it right there. Now we're in short at the end of it. So that's the kind of what we're looking for. Now, changing gears, one final time we're going to talk about appendicitis. One of my favorite topics. This is the most common surgical emergency in children. In children, the peak of appendicitis is between age 9 and 12 years old. And again, fever, abdominal pain, vomiting, anorexia, right lower quadrant pain, generalized abdominal pain that then localizes itself to the right lower quadrant. It turns out about a third of kids present without that classic presentation. And so whenever you have something that's not presenting classically, you got to turn to imaging. And you could get an X-ray, but you maybe get lucky and see what's called an appendicolith. That's basically translates to essentially a poop stone sitting in the appendix. What happens is a very sort of hardened, calcified stool can occlude the lumen of the appendix as it comes off the cecum, and that's what's known as an appendicolith. And the other thing you can see around that area is a focal ileus in that region, or where the bowel stops, what's like a focal bowel obstruction is what that means. So we get a surgery consult in a lot of these patients, and the first thing the surgeons many times, well, historically have turned to has been CT scans. Lately, though, I've noticed that especially our surgeons at UCI are getting very good about using CT as a last resort, and so that's been very reassuring to me, the approach to appendicitis. But you can see why they've historically have turned to CT scans. The sensitivity for CT is actually, with the new CT scans, the multi-detectors, it's all up around 96%, 98%. It's very, very good. Now with ultrasound, the sensitivity depends. It's a very operator-dependent thing, and some people are really good at doing these, other people aren't. It takes a lot of patience. The lower specificity that we see with ultrasound has to do with the fact that it's really difficult to see a normal appendix. And in fact, even in the best of hands, a normal appendix is seen less than 15% of the time. So feast your eyes on that, my friends. That is a normal appendix, which you rarely, if ever, see. We can see the iliac artery here, and it's just kind of stretching out over the iliac artery. Along its, this was an 18-year-old woman I had who had right lower quadrant abdominal pain, and on this longitudinal scan, we're able to see the longitudinal scan of the appendix, I should say, the long axis of the appendix. We're able to see this tubular blind-ended structure with nice thin walls, and if you measure from outer wall to outer wall, okay, here to here, here to here, here to here, you're going to get less than 5 millimeters, and that's normal. You can get up to 6 millimeters to have a normal appendix. Now, just to show you on a CT scan what it looks like, this is abdominal skin out here. This is fat. We can see all this around the body here. So this is actually the human being here, and this is all society influence out here. This is all just fat and stuff. So, and that's where ultrasound can be difficult if you have to compress all this fat here in order to get to see the muscle. So this is abdominal oblique muscle. This is the rectus abdominal muscle here, and we can see this thickened appendix right here, and we can see the psoas muscle over here. So the idea is to compress this abdominal wall musculature until the appendix gets squished between abdominal oblique. Sometimes the appendix is a lot more medial, and we can actually end up compressing this rectus muscle or abdominal oblique all the way down until you come in contact with the psoas muscle. And if you have acute appendicitis, the appendix gets stuck between these two muscle layers with ultrasound. So you're pushing the probe way out here and squishing the tissue all the way down. So you can imagine how much pain medication you may have to give a patient in order for them to allow you to compress it. And so basically that's what you're doing. You're just kind of, it's like, you know, you wait for it, wait for it, wait for it, and then all of a sudden you should see the appendix eventually pop its head out at you, and then as fast as you can see it, it's gone again because you moved past the area. Then you go, oh, wait, back up, and then you go back, and you're like, wait for it, you're compressing, and then all of a sudden, whoop, pops its head at you, and then you can freeze the image and show that to somebody. It's kind of what we're seeing here. We're going along, we can see some bowel peristalsing here. Here's psoas muscle right here, and psoas muscle is being compressed. You're basically, the probe is up here on the skin line, subcutaneous fat. Here's muscle right here, and we're going to push that abdominal wall musculature all the way down until it comes in contact with psoas. And we can see some psoas right here, and here's a loop of bowel right here. Maybe that's the appendix, I'm not sure. But it gets squirts out of the way. Here's some iliac vessel here. That appendix becomes ovoid and squishes out of the way, and it's nicely peristalsing. So in this case, this is definitely a negative study from what we can see so far. I should say no appendicitis visualized is the way you kind of document it. But that's the idea. Here's another case. I'm going to show you a bunch of positives now. This is, so we can see some abdominal wall musculature here. Maybe this is rectus. Maybe this is abdominal oblique. And here's what it looks like when it's positive. It's non-compressible tubular structure. This one measured to almost a centimeter wall to wall there, outside wall to outside wall for the appendix there. And let's see, here's another one here. I think they came to, here they're going to measure this sort of outside wall to outside wall, and I would actually drop the caliper right here. I think this is an example of where not to drop the caliper, but the idea is you want to go here to here. So it's a little bit less than 8, probably 7, still abnormal. Now in this case here, we're just doing a lot of compressing, and no matter what, how hard we compress, we're walking around everywhere, compressing. Here's some psoas muscle. Here's some bowel peristalsis with some air in it, abdominal oblique. We see loops of bowel with fluid. Here's psoas muscle right here coming. We saw psoas. It looks like psoas is coming up this way. What's happening is we're pushing this all the way down towards psoas, right? So all this tissue is compressible. We never see the appendix. We see a lot of peristalsis bowel, but we don't actually see the appendix here, and that's part of the study. So when you practice on this, this is likely what you're going to see in a normal individual. Just psoas coming all the way up and coming in contact with your abdominal oblique. And this patient here has got acute appendicitis. We can see this blind-ended tubular structure. We're doing a lot of compression. It's non-compressible tubular structure in the right lower quadrant. This one's 8 millimeters. So this is kind of the idea. Here's without compression. This is a still image protocol without compression. This is with compression here. We see the psoas muscle is here. We see the iliac artery, iliac vein, and then when we compress them together, here's psoas, and here's the appendix. It's non-compressible. We're able to squirt out away some of the free fluid. When you see free fluid like that, it actually helps to outline the appendix. You can see it easier, and that free fluid may be one of the tip-offs that there's been perforation of the appendix, and these patients may be quite sick, have elevated white blood cell counts, be febrile, and require immediate IV antibiotics and surgical consultation. I've noticed that more and more lately with perforated appendicitis, patients are getting IV antibiotics and not surgery, depending, and that's a case-by-case thing, but it seems like the trend is towards conservative therapy with IV antibiotics and setting a perforated appendicitis rather than going in and doing a washout. So to conclude here, I just want to show you this is what we want to do with the ultrasound technique. It's good to have a full bladder. I know that sounds uncomfortable, but that's part of it. The way we get around some of the discomfort of doing appendicitis ultrasound is with analgesia. I'm a big fan of a short-acting narcotic like fentanyl, which can be given, and you push it, the patient feels great. 20 minutes later, it's out of their system. That's why I like that drug. And but any short-acting narcotic will work that way. You want to start at the area where the patient tells you they are maximally tender. I hand the probe to the kid and say, "Here you go. Push on your skin where it hurts, and look up at the TV screen, and let's see if we can find what's bothering you." And the kid sort of gets into it. It's like a video game. And again, it's the psoas muscle. You want to be able to identify the iliac vessels and not call those appendicitis. This is just another example here of appendicitis. Here we can see a fecalith or a poop stone in the distal appendix causing a shadowing here, and that's nice when you can see them. It's kind of rare, but when you see one, it's pretty cool on ultrasound. It looks just like any other stone does, kidney stone, gallstone. Otherwise, it exudes some shadowing. So in general, ultrasound is a great alternative to doing a CT scan. We want to think about giving the patient some analgesia. It's important to have the patient in the right position of comfort, and always look at things in two views. We've talked a lot about the pylorus and the intestines and the heart. In all these, whenever I mention organ, you'll notice there's a recurring theme here. I talk about looking at things in two different views, and you're reconstructing that anatomy in your brain in a three-dimensional image, and that will come to you over time. Target signs with intussusception, and I think about ultrasound in terms of ruling it in because it has ultrasound has a poor specificity for appendicitis, so I can't really rule it out. But it does help to avoid a CT scan if I can rule it in. Now, just one more thing. Just keep in mind, again, for CT scans, that one of the ways I explain it to patients who sometimes patients are kind of demanding they want a CT scan right now, and if I think I can get there another way, or if I can talk them out of it, this is one way I say that. A CT scan of your abdomen and pelvis is like getting 500 chest x-rays. A CT scan of your chest is like 400. You can read all these here. And then if you look up the number of chest x-rays worth of radiation for an ultrasound, it's still 0. Thank you very much.